Today, we are preparing a massive 100-word dental vocabulary lesson, specifically looking at terms 100 through 200 from the lexicon. But instead of just memorizing some dry textbook list, we're going to completely reframe how we learn this. We'll be grouping these instruments and procedures by their actual purpose and walking through them in a strict chronological order, from the very beginning of a patient visit right through to the end. So let's see exactly how these tools function in the real world.
Here is our roadmap for this explainer. We'll start with Welcome to the Chair, move into Diagnosis and Discovery, then hit Numbing and Isolation, Drilling and Restoring, Specialized Surgeries, and finally, Sterilization and Prevention.
All right, Part 1. Welcome to the Chair, Patient Assessment and Clinical Setup.
So, the very first thing we do is classify exactly what kind of teeth we're actually working with. Are we looking at deciduous teeth? You know, those temporary baby teeth in our pediatric patients? Or are we dealing with permanent adult teeth? In some cases, our patient might be completely edentulous, meaning they have absolutely no teeth at all. Setting this baseline is absolutely crucial for everything that follows. Next up, the setup flow. The patient settles into the dental chair. But before even touching the patient, the dentist has to gear up, donning their PPE, that's personal protective equipment. This means pulling on gloves for the hands, a mask for the face, and loupes, which are those fascinating high-powered magnifying glasses dentists wear to see super tiny details. Meanwhile, to protect the patient, we drape a napkin called a bib around their neck, securing it tightly with the bib clip.
Now, before we proceed, we have to pinpoint the patient's chief complaint. Basically, we need to figure out, is the patient completely asymptomatic, meaning they're sitting there with no pain or symptoms at all? Or are they sensitive, like maybe they're feeling a sudden sharp pain when drinking something hot or cold? Finding this out dictates our entire investigative path.
Moving right along to Part 2, Diagnosis and Discovery, Tools and X-rays for finding the problem.
When we jump into the formal dental examination, we use a really interesting array of diagnostic tools. We always start with the mouth mirror, right? That tiny little visual tool used to peek around dark corners. Then there's the explorer, or probe, that sharp little hook you probably recognize, which is physically used to feel around for cavities. We also use a periodontal probe. Think of it like a tiny ruler that measures your gum health. Using all these tools, we perform a caries risk assessment to gauge cavity likelihood, an oral cancer screening to check the soft tissues, and a TMJ evaluation to make sure the jaw joint isn't popping or causing pain.
But to see beneath the gums and actually look at the bone, we have to turn to radiography. Crucially, we protect the patient first by throwing on a lead apron, a really heavy protective shield. Then, using our X-ray machine, we take specific images. We might grab a Panorex, which is a panoramic shot showing the entire head and jaw. If we're hunting for interproximal decay, you know, cavities hiding right between the teeth, we use a bite wing. Need to see one single tooth from the crown all the way down to the root tip? That's a periopical, or PA. And for advanced 3D planning, like if we're doing implants, we rely on a CBCT scan.
Part 3. Numbing and Isolation, Preparing the Mouth for Treatment.
Okay, so numbing and isolation are critical here. We use a syringe and its sharp tip, the needle, to deliver local anesthesia. For highly anxious patients, we might even turn to sedation dentistry, where the patient is completely asleep. Once they're comfortable, we isolate the work area. We use a retractor, a handy plastic tool to hold the lips open, along with small cotton cylinders called cotton rolls to keep the mouth dry. Often, for ultimate dryness, we deploy a rubber dam, a latex isolation sheet that perfectly separates the specific tooth from the rest of the mouth.
Part 4. Drilling and Restoring, Fixing Cavities and Rebuilding Teeth.
Now this is where we see the ultimate clinical balancing act. On one hand, we have our drills, formerly called handpieces. The high-speed handpiece is the loud, incredibly fast drill for heavy cutting, while the slow-speed handpiece vibrates slower and is mostly for polishing. And right at the tip of these handpieces sits the burr, which is just a tiny little drill bit. While we're cutting away tooth structure, we absolutely have to manage the water and debris. So we bring in our evacuators, the high-volume evacuator, or HVE, for really loud, fast suction, and the saliva ejector for slower suction. Simultaneously, the assistant is constantly using the air/water syringe to spray water and air, keeping the whole area clean and visible.
Once the decay is totally gone, the actual dental filling procedure begins. We pack the hole with restorative material, either amalgam, which is your classic silver filling, or composite, a natural-looking tooth-colored resin. To shape this perfectly, we wrap a matrix band around the tooth. It acts like a little metal ring or temporary wall, and we wedge it in place with a tiny wooden stick, literally called a wedge. If we use that tooth-colored composite, we instantly harden it with the curing light, which blasts it with a bright blue UV light. Finally, we finish up by checking the patient's bite using articulating paper, that colorful paper the dentist asks you to bite down on.
But hey, what if the damage is just too extensive for a standard filling? Well, that's when we pivot to indirect restorations, things made in a dental lab. We start the process by taking a mold of the mouth. This is called impression taking, using gooey impression material sitting inside a plastic or metal impression tray. The lab takes that mold and gets to work. If a tooth is heavily broken, they'll make a protective cap for a crown placement. Missing a tooth entirely, we'll do a bridge placement to connect adjacent crowns together. For purely aesthetic upgrades, we might do a veneer placement, gluing thin porcelain shells right onto the facial surfaces of the teeth. Sometimes we do inlay or onlay procedures. These are custom, lab-made fillings that fit perfectly inside or over the tooth biting surface. And for our edentulous patients with no teeth, we provide a denture fitting to give them completely removable fake teeth.
Part 5. Specialized surgeries, endodontics, periodontics, and oral surgery.
Let's dive into endodontic terms for a second. This whole specialty relates strictly to the inside nerve of the tooth. When a nerve becomes infected, our primary fix is a root canal treatment, or RCT, to remove that infected tissue. If our patient is a child, however, we do what's basically a baby root canal, called a pulpotomy or a full pulpectomy, which removes all the pulp from that baby tooth. In really tough, extreme cases, an apicotomy is performed to surgically remove just the tip of a tooth's root. Finally, if decay gets dangerously close to the nerve but hasn't infected it yet, we might try to save it by placing medicine on or near it using a direct or indirect pulp cap.
Shifting focus to the gums and bone, we enter the world of periodontal terms. The foundational procedure here is scaling and root planing, which is essentially a very deep cleaning of the gums and roots. For this, we use a scaler, a sharp tool to scrape away hard tartar, and a curette, which is specifically designed to clean deep underneath the gum line. More invasive procedures in this category included gingivectomy to cut away excess gum tissue, flap surgery, where we actually peel back the gums to clean underneath them, or a gingival graft, which involves taking a little bit of skin from the palate and adding it to receding gums.
Unfortunately, sometimes a tooth just can't be saved. So what's the chronological flow of a tooth extraction, pulling a tooth completely out of the socket? It's pretty fascinating. First, we use an elevator. This is a tool designed to gently loosen the tooth from its socket. Once it's loose, we use forceps, which are essentially dental pliers, to actually pull the tooth. Immediately after, we apply gauze, a cotton material, to stop the bleeding. Finally, the dentist might perform an alveoplasty, a quick surgical procedure to smooth out the jawbone after the extraction so it heals properly.
We also have to talk about highly advanced surgical interventions. A scalpel is used for making precise surgical cuts, which later requires suture removal to take out the stitches. If we find any suspicious tissue, we perform a biopsy to test it. Have a severely painful abscess? That requires an incision and drainage, known as an I&D, to let the infection out. We also literally rebuild smiles from the bone up by placing titanium dental implants. Often, to make room for those implants, we have to do bone grafting or even a sinus lift to build up the jaw. Other highly targeted procedures include a root amputation to slice off one specific infected root on a multi-rooted tooth, a frenectomy to snip a tight muscle attachment under the lip or tongue, or even full-blown orthognathic surgery for complete corrective jaw alignment.
Moving beyond surgery, we encounter orthodontics and some other specialized restorative treatments. Orthodontic treatment is all about moving teeth into proper alignment, using either traditional braces, wires and brackets, or Invisalign treatment, which uses clear plastic trays. Once that treatment is done, a retainer delivery is required to keep those teeth straight. In kids, a space maintainer placement holds a gap open if a baby tooth falls out too early. Now, if teeth get knocked loose in an accident, we use tooth splinting to tie them together for stabilization. We can also perform an occlusal adjustment, filing down teeth to fix an uneven bite, and for pure aesthetics, teeth whitening or bleaching to make that enamel significantly brighter.
Part 6. Sterilization and prevention, concluding the patient journey.
The workflow concludes firmly behind the scenes, shifting focus completely to prevention and safety. All those tools we just talked about, they're sent straight to the autoclave, an incredible machine that sterilizes everything using intense, pressurized steam. Meanwhile, for the patient, prevention is the final step. We might perform a dental prophylaxis, which is your standard routine dental cleaning. We do a fluoride application, painting on a mineral varnish to strengthen enamel and fight off decay. For those really deep congenital grooves on the biting surface, we paint on a plastic coating called a sealant. And for patients who tend to grind their teeth at night, their visit might just end with a night guard delivery, sending them home with a custom plastic tray for protection.
Let's just take a second to reflect on this entire workflow. By grouping these instruments by their intended use and seeing them in this true chronological sequence, we realize something really cool. Clinical vocabulary isn't just a random list of words to memorize. It's the actual script of a highly choreographed medical dance. Understanding how it flows from start to finish makes modern dentistry so much clearer.
So, with our chronological journey complete, you're definitely no longer just a passive patient. Which of these clinical terms will instinctively pop into your head the next time you hear that high-speed handpiece start up or see the dentist reaching for the mouth mirror? Think about that the next time you're sitting in the dental chair. Keep exploring, and I'll catch you in our next explainer.